Hello, this is Dr. Artie Kavanaugh, and we're going to be talking in the next few minutes about some new data about new and emerging biologics. To set the stage, one thinks of IL-6 as being a cytokine that's involved in many processes, and indeed that is the case. And as is shown on the cartoon, IL-6 does many things to many types of cells, and many of the activities will ring familiar to us in rheumatology because they also are things that we will see or can feel to be consistent with the characteristics of the immunopathophysiology of rheumatoid arthritis. So IL-6 will stimulate B cells, will help activate T cells, can have a direct effect on bone, leading to or accelerating damage and loss of bone stock, can activate synoviocytes, and has a number of other activities. So from a purely theoretical standpoint, it would seem that inhibition of IL-6 could indeed be of some therapeutic value in patients with rheumatoid arthritis and potentially some other systemic inflammatory autoimmune conditions. Now, most of us are quite familiar with data from tocilizumab. Tocilizumab, the first IL-6 inhibitor that was brought into the clinic and is approved for use in many countries throughout the world. We've learned a lot about the data, the pivotal studies with this drug that led to its approval. There's a very interesting recent study which I would like to highlight to some extent, and I think it points to an issue that is quite relevant to clinicians, namely when you have patients who have come in to see us in the clinic and get started on methotrexate, and then we say we're not really happy with the level of clinical response. We might call them incomplete responders. What do you do next with that person? And two options are to add a second agent and hope that the methotrexate plus a second agent will be additive or even synergistic. But the other option is to switch from methotrexate to a second agent. So we've seen data on this over the years with methotrexate and other oral DMARDs. We've seen some data with methotrexate and TNF inhibitors. And this study, the ACTRAY Study, is a study of that similar question in patients with rheumatoid arthritis, methotrexate incomplete responders. Should you add or should you switch to an IL-6 inhibitor? And this study was done with tocilizumab. So the data are shown here, and it's interesting. We've seen the clinical data, which were presented at EULAR earlier this year, and this data were presented at ACR. And to review the clinical data would seem to indicate that it may be as good or certainly nearly as good to switch to an IL-6 inhibitor in patients who are methotrexate incomplete responders, such that the clinical responses seem to be quite comparable for those who were on methotrexate and added tocilizumab compared to those who were on methotrexate and switched to tocilizumab. This data now looks at the change in the Sharp score. This is a Genant-modified Sharp score, and looked at in a number of different ways. What is the difference in the patients who have tocilizumab added versus those who have it switched? And then you can see is that the difference is in the change in Sharp score, not statistically significant. The number of patients who have zero progression, it may be numerically a little bit higher in the combination group, but not statistically significant. And looking at functional status, both by the change in actual HAQ score and also looking at quality of life, it appears that the strategies are very close. So this data would suggest that in patients who are methotrexate incomplete responders, perhaps you might do as well by switching to tocilizumab as opposed to adding tocilizumab. And that's, I think, an interesting discussion. Frequently this comes up with patients because many patients, if they were able to, would prefer to decrease or even discontinue the methotrexate. So a lot of excitement about IL-6 inhibition. Tocilizumab was the first that we've had available to us in the clinic, and as always in medicine, certainly in rheumatology, success breeds success, and now we see that there are quite a number of other IL-6 inhibitors in development. Interestingly, there's a little bit difference in the strategy. So tocilizumab is an antibody to the IL-6 receptor, and as you can see, there are a number of strategies to the IL-6 receptor, other strategies inhibiting IL-6. There are a number of ways to inhibit the interaction of IL-6 with its cognate receptor, and then subsequently the interaction of IL-6 and its receptor with GP130, which is the signaling molecule present on many of the target cells. We don't know if these strategies will be different, if there might be any distinct issues with efficacy or safety between the two of them, and that's something we'll certainly look forward to. Some data was presented with one of these products, and that's sarilumab. It's another anti-IL-6 receptor monoclonal antibody, and what was presented at ACR was a 12-week randomized controlled trial of quite a number of different doses of this agent because it is in earlier phase development. The primary outcome was the ACR20, and this was reached at the highest dose, but when you look at the ACR20 responses, it's a pretty high placebo response, and that's not something we like in studies because it makes it harder to really dissect what the active treatment could do. Just the highest doses reached statistical significance, although there was a trend for some of the lower doses at the higher levels of response, such as the ACR70. Interestingly, the safety signals with this agent seem to be similar to what we had seen with some other IL-6 inhibitors, including tocilizumab. Namely, some patients had a decrease in their white count, particularly neutrophils. Some patients had an increase in liver function. Some patients had an increase in cholesterol. So these signals seem to be what we would have expected with this particular target. Another agent in development is sarilumab. This one is an antibody, monoclonal antibody to IL-6, not to the IL-6 receptor. This, too, was a relatively early phase study. In this case, the primary endpoint was the ACR50, not the ACR20 response at week 12. And here, different doses and dosing strategies were used. And although there seemed to be perhaps a greater numeric response at the highest dose, all the AE doses seemed to do relatively well, with perhaps the exception of the very lowest dose. As we saw with the other IL-6 targeted therapy that we just spoke of, safety signals similar to what we saw with other IL-6 inhibitors, the leukopenia, increase in lipids, increase in liver functions in some patients. So in this study, looking at the data, it would suggest that the efficacy of blocking IL-6 by blocking IL-6 itself or by blocking IL-6 receptor can both be viable options. And I think we look forward to longer-term studies of these agents. And just as we've learned how to use the 5 TNF inhibitors we may have that many IL-6 inhibitors in the years to come. In addition to rheumatoid arthritis, there is a lot of interest in inhibition of IL-6 in other disease states. One of those that's gotten a lot of attention and actually has resulted in approval in the United States and in some other countries is systemic onset juvenile idiopathic arthritis, a condition that it can be very, very severe with children that are just very severely disabled by fevers, by the joint involvement, by the other systemic symptoms that they have. The data presented at ACR were 2-year data follow-up of the TENDER study. This is an initial blinded study of tocilizumab in patients with systemic onset juvenile idiopathic arthritis that's now going out. This is data for 2 years, and the study will be continuing. A couple of things of note. One is that the levels of clinical responsiveness seem to be pretty impressive, such that the number of patients with an ACR70, the juvenile idiopathic arthritis version of the ACR70, those patients with inactive disease, and those patients who were able to completely stop corticosteroids, really pretty notable out through 2 years now of follow-up. On the other hand, there were a number of serious adverse events and several deaths that were reported in this study. Now, these children are very, very sick children. Most of these children have failed a number of other biologic agents already. The use of corticosteroids is very common in these patients, so it's a subset of patients with very severe disease, but I think we have to respect that powerful immune modulating agents are things that we need to monitor closely for the potential toxicities. And just as we've learned with the TNF inhibitors, the more we know about what to look for, the better we are able to stratify the patients and hopefully either prevent or acutely treat things that we might see in terms of safety. On the next slide, we see a review of the potential safety issues that I think we will see across IL-6 inhibitors. It seems like we'll see these issues with agents targeting IL-6 or targeting the IL-6 receptor, that anything that's going to be effective may be associated with some of these side effects. So these are things that we have learned to understand and learn to look for in the clinic, and the more data we have on them, I think the better we'll be able to manage our patients with this kind of immune therapy. Talking about a different therapy, just an offshoot, but also in the same disease, systemic onset juvenile idiopathic arthritis. There was an abstract presented at the ACR meeting in 2011 on canakinumab. Canakinumab is a monoclonal antibody directed against IL-1. And we know from many years that inhibition of IL-1 didn't seem to work out very, very well as a treatment for adult rheumatoid arthritis. But what this data show is that blocking IL-1, at least as shown in this study with this agent, seemed to be quite effective in patients with systemic onset juvenile idiopathic arthritis. I guess we have heard from our pediatric colleagues that they often will use another IL-1 inhibitor, anakinra, in their patients with JIA, and this suggests that inhibition of IL-1 may actually be another viable target in patients with this very severe systemic disease. So very high, quite notable levels of responsiveness to inhibition of IL-1 in patients with systemic onset juvenile idiopathic arthritis. So we've talked about IL-6, talked a little bit about IL-1. I want to shift gears and talk a little bit about another potential target, and that's IL-17. IL-17 has come to be viewed as a potential target in a number of systemic autoimmune conditions, including rheumatoid arthritis, but also ankylosing spondylitis, psoriatic arthritis, skin psoriasis, and other immune diseases. There's a lot of scientific rationale for why it might be a viable target, in that Th17 cells, the T cell subset that produces IL-17, could be thought of as playing a role in these immune diseases, as we said, rheumatoid arthritis, psoriasis, ankylosing spondylitis, psoriatic arthritis. It's a pro-inflammatory cytokine. It drives other cytokines, including TNF, which of course we know the importance of, and also IL-22, which is particularly important for skin inflammation. The idea of targeting IL-17 then seems to have a firm rationale, and there have now been a number of studies that have begun to address this as a possible therapeutic intervention in patients with autoimmune disease. Several studies were presented at the most recent American College of Rheumatology meeting. This one is a monoclonal antibody directed against IL-17, and this shows a result of a study in patients with rheumatoid arthritis, and looking at different subsets of patients. Some patients had been incomplete responders to traditional DMARDs, mostly methotrexate. Others had previously been exposed to a TNF inhibitor. Now we know that patients who've been exposed to a TNF inhibitor, it is a very refractory group of patients. So the results from there, it's not uncommon that they are a little bit lower. Results in this show that there are some statistically significant differences in the different groups, and not a clear dose response with inhibition of IL-17, but there seems to be some distinction between the active treatment and the placebo in both groups of patients, both the biologic naive and the biologic exposed patients. So I think this is an area where the jury is still a little bit out, and perhaps not as robust responses as we would expect or have come to see with inhibition of TNF, or for that matter, perhaps with inhibition of IL-6, but there are clear responses, and I guess what we may look forward to in the future is being able to subset patients to know who might be the best candidates for particular kinds of therapies, and perhaps we can identify who might be the best candidates for inhibition of a particular cytokine such as IL-17 versus those who might be a better candidate for inhibition of TNF or IL-6. I think that's the promise that we'd all like to see for the future in rheumatology, for being able to optimally care for our patients with rheumatoid arthritis and other systemic autoimmune diseases. Thank you for listening.